Delhi. And the history was given by mother, who is a reliable informant. So, child presented with chief complaints of recurrent episodes of loose stools for 2 months, fever for 3 days, which was 2 months back, vomiting for 2 days, 1.5 month back, and decrease in appetite for 15 days. Child was apparently well 2 months back when he joined swimming classes. After that, after 2 weeks of joining classes, child developed fever, which was acute in onset, intermittent, 3 to 4 episodes per day. Maximum documented fever was 102 degree Fahrenheit. Fever relieved with medication, not associated with chills or rigor, and resolved on third day of illness. Then fever was associated with loose stools starting from second day of illness, and which was acute in onset, approximately 8 to 10 episodes per day, moderate in quantity, watery yellowish in color, contained undigested food particles, and stool was not blood tinged and non-mucoid stools. On third day of illness, parents consulted local doctor where antibiotics were given, and due to persistence of symptoms, child got admitted on fifth day of illness. And where child was managed conservatively, antibiotics were given, blood and stool investigations were done, which came out normal, and discharged on eighth day of illness on oral antibiotics. When symptoms relieved temporarily for 4 days after stoppage of antibiotics, then again, child developed symptoms, and then he was managed on OPD basis. Then intermittently he got relieved, again having the episodes. Now the episodes are foul, like loose stools or foul smelling, greasy, large quantity. Then child again admitted on 1st July, where investigations were done, suggestive of infective etiology, antibiotics were given, symptoms relieved, and discharged after 3 days of admission. Again, after discharge, 4 days of discharge, child developed symptoms. With these complaints, child was brought to SGRH. History of weight loss is present around 2 kg in 2 months, contributing to 10% of decrease in weight, associated with decrease in appetite, lethargy, associated with decreased physical activity. And coming to negative history, so for the etiology, I have asked the history of persistent high grade fever, blood or mucus in stools. So basically, to rule out the infectious causes of diarrhea, among infectious also the bacterial etiology. Basically, in bacterial etiology, they have high grade fevers and blood in stools and mucoid stools. So I have asked this. Then the second will be no history of tenesmus, abdominal pain, nocturnal fecal urgency, joint pain, swelling, rash, redness of eyes, recurrent oral ulcers. All these complaints I have asked to rule out the inflammatory bowel disease, including the Crohn's disease or the ulcerative colitis. They have systemic complaints. So I've asked this. Now, the next is no history of recurrent diarrhea, pallor, poor height or weight gain to rule out the disease like at this age of present at this age celiac disease can present with all these complaints. Increased bowel, there is no history of increased bowel movement after meal related to some malabsorption symptoms, lactose intolerance. Then no history of excessive thirst, sunken eyes, drowsiness, decreased urine output, diarrhea-related complications like for dehydration. I have asked this. Then no history of abdominal distension, perianal excoriation of the skin, and flatulence for malabsorption. Like in carbohydrate malabsorption, there is increase in the stool pH will be acidic that cause the perianal excoriation. There is no history of prior drug intake that is responsible for these low stool episodes. No
Go
history of
previous slide once. Go in the previous slide.
yes.
So, on the basis of history, students should be able to differentiate between whether it is a small bowel diarrhea or large bowel diarrhea. Other thing is in the we basic on the pattern of stool we divide it in the watery diarrhea or bloody or inflammatory diarrhea.
Yes.
Okay, or the fatty diarrhea. So, what do you think from the history, like what you presented before? Is it in the classification of watery, or is it bloody, inflammatory, or fatty? Your case.
It's ma'am, watery diarrhea, ma'am.
Okay, it's in the watery diarrhea. Then
Yes, ma'am.
comes whether it is osmotic or secretory. Because you asked for the history of whether there was increased bowel movement after feed, after meal, or whether it has some relation to fasting. Because in
Yes, ma'am.
osmotic diarrhea, it will increase with the meal, and with the fasting, it will decrease. But on the secretory diarrhea, there will be no such relation with the meal or keeping the child fasting. Diarrhea
Yes, ma'am.
will improve in secretory. So on the basis of history, you should be able to differentiate between what type of diarrhea you are dealing with.
Yes, yes, ma'am. It's more likely in favor of secretory diarrhea, ma'am, because there is no relation to meal and
How will
fasting.
you differentiate between whether it is small bowel or large bowel?
Ma'am, in small bowel diarrhea, there'll be watery stools, explosive stools, and there'll be more other symptoms like vomiting and periumbilical abdominal pain is usually present in small bowel diarrhea. And in case of a large bowel diarrhea, there will be um, the frequency will be more, and there is a quantity of the stool will be less, and they have blood and mucus in stools. So on this basis, we can differentiate, ma'am.
Okay. And also, fecal volume, basically, it will be more in the small bowel diarrhea.
Okay.
Large bowel fecal volume will be less, more of mucus, blood, tenesmus, urgency. These kind of symptoms will be in
A
which
large bowel diarrhea.
is large bowel diarrhea. Okay. And
Hanji.
the features of malabsorption, steatorrhea, these will be in small bowel diarrhea. Okay.
Yes.
Go ahead.
And there is no history of contact with TB, no history of chronic constipation, no history of recurrent infection, and no history of excessive juice intake.
So why you have asked all this to justify?
Ma'am, excessive juice intake can be related to toddlers' diarrhea because of increase in the carbohydrate content, decreased fat content, increase in fluid intake can lead to the osmotic diarrhea. So in this, we have to do the dietary modification basically. So that's why I have asked this excessive juice intake, ma'am. History of recurrent infection for ask if there is any immunodeficiency that is responsible for these diarrheal episodes. And history of chronic constipation, I have asked because
Recurrent infections basically you will ask because your child is heavy. First, tell me the definitions of acute diarrhea, persistent diarrhea, prolonged diarrhea, chronic diarrhea.
ma'am, acute diarrhea is if the symptoms, the loose stools, that the episodes are acute in onset and usually subside within 7 days. And if the symptoms present acutely and if it persists more than 7 days till 14 days, we call it prolonged diarrhea. And if the symptoms persist more than 14 days, then we call it persistent diarrhea. And if the symptoms present more than 4 weeks, then we call it chronic diarrhea.
Okay. And what is the definition of diarrhea?
Diarrhea, ma'am, there's change in frequency and consistency of stools, and with more than 3 stools per day, like as given in Nelson, ma'am.
Okay, thank you. Now, justify all these points on this slide.
Yes, ma'am. So history of chronic constipation, I have asked because in case of chronic constipation, there can be overflow incontinence. And in case of chronic constipation, there is a small intestine bacterial overgrowth that causes the enterocolitis and the diarrhea-like episodes. Contact with TB, I have asked because there is history of weight loss along with these diarrhea episodes. So I have asked the history of TB and the prior drug intake I've asked because of the drug related diarrhea like antibiotic associated diarrhea or the certain other drugs including laxatives, the magnesium containing syrups. This can cause diarrhea. That's why I've asked.
Okay, fine. And recurrent infection?
Recurrent infection, ma'am, in case of the immunodeficiencies, the patient can present with recurrent episodes of diarrhea.
Yes. So primary and secondary immunodeficiency both should be kept in mind. Okay.
Yes. Then there is no prior history of admission with similar complaints. And coming to birth history, the child was born out, at full term by vaginal delivery. Firstborn cried immediately after birth. No history of delayed passage of meconium. No history of NICU stay. Then developmental history. The developmental milestones are appropriate for age. Among motor, child can walk downstairs with alternating steps, hop on one foot, can copy, cross, imitate gait. Among social milestone, goes to toilet alone, can dress with help. In cognition, can name 5 to 6 colors. And language can tell stories, can use 4 word with sentences. So developmental quotient based on the history is 100. Then
Or
coming,
history, when you are taking the development history and this is a case of chronic diarrhea, then you should also tell that the child is toilet trained or not. Okay,
okay,
at which age child had toilet training, it also becomes important.
okay. Then immunization history, the complete immunization under national immunization schedule. Child has taken all the vaccines according to schedule appropriate for his age. Coming to dietary history, the pre-illness dietary history intake in 24 hours. So as per the history, the total calorie intake is 912 kilocalories and required is 1360 kilocalorie per day. So calorie deficit came out is 448 kilocalories and protein deficit is like 15 is adequate only 1 gram per day deficit is. Then family history, child resides in nuclear family and is a product of non-consanguineous marriage. No history of similar complaints in family. No history of TB contact in family. Then socio-economic history, child belongs to nuclear family. There are 3 family members. Head of the family is father. So as per modified Kupuswamy scale, child belongs to upper middle class family. And for water sanitation, they drink water from the water purifier. So, on the basis of history, my summary is 4-year-old child developed an acute febrile illness 2 weeks after joining the swimming classes and had low to moderate grade intermittent fever lasting for 3 days, followed by profuse watery diarrhea, 8 to 10 episodes per day without blood. Despite multiple course of antibiotics and 2 hospital admissions, the diarrhea recurred after temporary improvement. So, over the time, the stools becomes foul
Uh,
smelling.
Go
Yes,
on the previous slide, Kashish.
yes.
So when you are saying that despite what is the most likely etiology based on your summary? Like how
Ma'am,
it started and how it is going.
Yes, ma'am.
Well,
Most likely etiology is infective diarrhea only because initially they have history of joining swimming classes. After 2 weeks, child had developed the symptoms. So most common etiology among the infection, if we say, so they're related to giardiasis, cryptosporidium, or in among bacterial the clostridium jejuni also can cause these kind of symptoms, and initially it has watery diarrhea, so because of the acute infection later the stools become greasy, bulky, suggestive of some malabsorptive symptoms can be due to secondary malabsorption because of the disruption of the mucosa.
okay, so yes, you are right that the first etiology will be the infective etiology as per the history. And
Yes,
the last line you have written that despite the multiple course of antibiotic, hospital admission, diarrhea has recurred. So basically, the emphasis is that even after taking antibiotics, the diarrhea has not improved. The cause can be reinfection. Sometimes
green.
when they are just recovering from the first GI infection, they again get the same infection through the oral fecal route or maybe some other enteric organism. So
Yes,
they will be in a vicious cycle of infection, malabsorption, or malnutrition, then again infection. So the infective etiology can be prolonged for, because in this case you are saying it was lasting almost for 2 months.
yes, ma'am.
So that can be the one etiology. Other can be that there can be infection on some superadded illness.
Yes, ma'am.
Okay.
Then, on the basis of summary, my differential diagnosis first will be infective diarrhea. So, points in fear of infective diarrhea is acute in onset, so initially associated with fever, and history of exposure is also present, the swimming pool, and temporary it respond to antibiotics. The second differential I have like put is celiac disease, because age is fitting in between like 4 year of age, and these are symptoms last from last 2 months. So it's a chronic diarrhea, history of weight loss is present, and history of like malabsorptive signs like greasy, foul smelling stools are present. But the points against the celiac disease are like history of swimming more points towards the infective cause, and a history of fever is present. Apart from that, there is no growth failure. There is no relation to diet, like related to gluten diet or what. So that's why I put it in second place. Third will be tropical sprue.
But
Uh,
other uh, what other clinical pointers which you can ask on the basis of history for celiac disease? Like, what are the point against? What all be other clinical manifestation a child can have with celiac disease?
Ma'am, मतलब mostly patients present with growth faltering, decrease in height, velocity, decrease in weight, and the malabsorptive symptoms like vitamin deficiencies, glossitis, cheilitis, all these symptoms can present.
Yes.
Then, uh, uh, yes,
Re-
ma'am.
Repeated oral ulcer, skin
Uh,
rash, arthritis,
yes.
delayed puberty, all these
Uh,
can be signs and symptoms, or just recurrent abdominal pain. Sometimes they just present with constipation. So celiac disease have like myriad of symptoms or
oh,
okay.
okay. Then third differential I have put is tropical sprue, as there is a history of chronic diarrhea, greasy bulky stools, weight loss, poor appetite, and it's like in tropical countries, like tropical sprue can be a possibility. But the points that against the tropical sprue, it's mostly occur in more than 5 years of age, and the history of the swimming pool exposure and improvement in antibiotics in between. These points against the tropical screw, as tropical screw has like they respond to antibiotics later, longer course of antibiotics required.
Yeah. In tropical sprue, basically it's an environmental enteropathy. So there will be infection, then there will be malnutrition, reinfection. So it's kind of, and it happens with your mostly like the ETC E. coli infections or the Giardia or the rotavirus because it leads to damage to the villi. The
Yes.
mucosal surface, the mucosal absorptive surface will be damaged, just like the celiac. So you'll have all the other malabsorption features, iron, B12, folic acid deficiencies. So they will be needing longer antibiotics along with the vitamin
Right.
supplementation.
Yes.
Okay, what other differentials you can keep here?
Ma'am, next we can keep is post-infectious lactose intolerance, as there is a history of the greasy, bulky stools in this patient. But there is no relation of milk intake in this patient, so that points against the lactose intolerance. And the last will be inflammatory bowel disease, like history of chronic diarrhea, acidoria, weight loss are present. But there is no history of mucus or blood in stools, no systemic complaints, nocturnal urgency, tenesmus not present. So that goes against the IBD.
Okay. Other differentials? Because you are clearly saying that your patient, after the diarrhea onset, he was having malabsorption features and he was having kind of steatorrhea.
Yes,
So,
ma'am.
what other differentials we will keep with the steatorrhea?
Ma'am, in case of malabsorption symptoms, we can keep the pancreatic insufficiencies, um,
Yes, CF you can keep here, cystic
cystic
fibrosis.
fibrosis. Yes, ma'am. But there is no history of recurrent episodes of infection prior to this episode. So, and no other systemic manifestations are present.
Okay, okay, fine. Go ahead.
Then coming to general physical examination. So child at the time of examination, child was lying comfortably on bed, alert, active, and conscious, oriented to time, place, and person. On vital assessment, temperature was 37 degree Celsius, measured with digital thermometer in axilla. Pulse rate was 115 per minute, regular and normal volume, all peripheral pulses palpable. BP was 100 by 60 mmHg, which was more than 50 centile, measured in right arm. Saturation was 98% in bone marrow. Pallor was present on examination, but no cyanosis, icterus, clubbing, or lymphadenopathy was present. On anthropometric assessment, weight of the child was 14.8 kg, height is 102 centimeter, mid upper arm circumference is 14.5 centimeter. So weight for as per WHO charts, weight for age for this child lies between 10 to 25th centile, and the weight for height lies between again 10 to 25th centile, and height for age lies between 25th to 50th centile. So this is suggestive there is a no acute or chronic malnutrition. Then a head to toe examination. The Head to toe examination was normal, head was normal, there were the hairs was normal, black texture. On eye examination, pallor was present, but no other signs of like vitamin A deficiency in eyes. No facial morphism was present. No on skin examination, there are no signs of vitamin deficiency. All cavity looks normal, tongue looks moist, no signs of dehydration. And nails, bone, and joints were normal. Genitalia and was normal. On per abdomen, now the systemic examination, per abdomen examination, child was examined in supine position. On inspection, abdomen was mildly distended, umbilicus central in position, inverted, no scar marks, no skin discoloration, no dilated veins, no ecchymosis or purpura, no visible peristalsis or pulsation. All quadrants move equally with respiration. Auscultation, bowel sounds is present, palpation, superficial, there's no local rise of temperature on deep palpation, liver borders for ill-defined, rounded margins, palpable just below the right costal margin. In mid-clavicular line, spleen was not palpable. On percussion, liver dullness on upper border, dullness is in fourth intercostal space, and the liver span was 6 centimeter. Systemic, the respiratory system, CVS and CNS examinations were within normal limit. Bilateral air entry was present on respiratory examination. No added sounds were there. On CVS, S1, S2 was heard normally. No murmur or gallop was present. On CNS examinations, child was active, alert, and higher mental functions were intact. No signs of vocal neurological deficit. So, on the basis of some history and physical examination, the summary is 4-year-old child developed an acute febrile illness 2 weeks after joining the swimming classes. Initially, he had low to moderate grade fever, maximum 102 degree Fahrenheit, lasting for 3 days, followed by profuse watery diarrhea without blood or mucus. Despite the multiple course of antibiotics, 2 hospital admissions, and the diarrhea recurred after temporary improvement. Over the time, the stools becomes foul-smelling, greasy, and bulky. And from past 2 months, child has history of weight loss around 2 kg, 10% of weight loss, poor appetite. On examination, pallor was present, and abdomen was mildly distended. No other signs of like vitamin deficiency or protein allergy malnutrition was present.
What are the signs of protein energy malnutrition?
Ma'am, in protein allergy malnutritions, they're starting from head to toe in hair. Child can have like depigmented hair, and the sparse hair will be present. Easily pluckable hairs will be present. Then on signs of child will be uh, uh, that monkey faces we can see in case of marasmus, and pot belly can be seen in case of kwashiorkor. Apart from that, ma'am, uh, the in case of like marasmus, there will be baggy pant like appearance in gluteal region because of excessive pasting and the loss of the subcutaneous fat. While in case of kwashiorkor, there will be edematous style.
Yes. Okay.
So the final diagnosis will be chronic watery diarrhea with no dehydration or protein allergy malnutrition, most probably infective etiology leading to malabsorption and weight loss.
So here 2 points that you can add is uh, chronic watery diarrhea with no dehydration or PM. Okay, most probably infectious etiology leading to malabsorption and weight loss with
Yes.
normal growth according to your anthropometry,
Yeah, yes, ma'am.
with normal anthropometry and with no vitamin deficiencies and with complete immunization.
Okay, ma'am.
What all vaccines will you suggest to this child if he has taken his vaccination in the national immunization schedule?
Ma'am, in NIS, we don't give the hepatitis A vaccine, typhoid vaccine that we can advise.
Okay. Other vaccines?
Some other vaccines that can cause diarrhea, including the rotaviral vaccines, OPV, and measles can also cause diarrhea. So all these vaccines are included in NIS. So
Okay. Go ahead.
and coming to a small discussion on the diarrhea. So, how to differentiate between small bowel diarrhea and large bowel diarrhea? In small bowel diarrhea, the volume will be larger, watery diarrhea, and nausea and vomiting will be prominent, and the pain, abdominal pain will be present, which is periumbilical, and it is not relieved after passage of stool. Signs of malabsorption like explosive diarrhea, greasy stools, nutrient deficiency will be present. There will be minimal urgency or tenesmus. While in case of large bowel diarrhea, the volume will be small, but there will be frequent stools, visible blood and mucus in stools. Nausea and vomiting will be less prominent. Pain will be in hypogastric region and which is relieved after passage of stool. There is a history of minimal weight loss and characteristic tenesmus will be present in case of large bowel diarrhea. Then coming to etiology based on the age, like in age less than 6 months, the cause can be like infectious causes. Infectious causes can be present in all age groups. Apart from that, cow milk protein allergy can present. One of the etiology in less than 6 months, urinary tract infection, short bowel syndrome. Then immunodeficiencies can present with this cystic fibrosis, glucose galactose malabsorption, intractable diarrhea of infancies. While in the age group between 6 months to 5 years, again the CMP can be a differential. Apart from that, celiac disease, GRDSS, toddlers diarrhea, then short bowel syndrome, tuberculosis, inflammatory bowel disease, and again immunodeficiencies, bacterial overgrowth syndromes, and pancreatic insufficiencies. In age more than 5 years, celiac disease will be another possibility. Apart from that, GIDS, gastrointestinal TB, IBD, immunodeficiencies, bacterial overgrowth syndromes, tropical sprue, and pancreatic insufficiency. Now, the approach to chronic diarrhea basically. So, if the diarrhea lasting for more than 4 weeks, then the proper history and physical examination should be taken and assess for the red flags. That includes if first we have to ask for the age of onset, whether it's a neonatal or in infancy or in toddler or it's a adolescent age group. Then the presence of blood or mucus on stools, if there's a nocturnal diarrhea and the other systemic signs that are present in IBD, unexplained fevers, persistent vomiting, growth failure, developmental delay, puberty is present. Then arthritis, eye or skin ailment for IBD, then hydration status for dehydration, then nutrition status, evidence of micronutrient deficiency is present or not, if there's presence of edema or not edema, like for hypoproteinemia, protein losing enteropathies can have edema. Then abnormal perianal examination, rash, tags, fistula or fissures are present, presence of abdominal distension or organomegaly. Then after the history and examination, go for the investigation. Investigations include the stool microscopy and culture to find out the infectious causes. And for that infectious causes, we can look for the stool WBC counts, then lactoferrin we can see. Then for Clostridium difficile, we can do the enzyme immunoassays, PCR we can do. And Clostridium difficile we investigate in more than 1 year, because in less than 1 year it can be commensal. Then total whole CBC should be done, RFT, LFT, CRPs, or celiac serology should be done. All the nutritional bloods as necessary we can do. And then if the RBCs are present and fecal calprotectin is more than 50 microgram per gram of stool, then there will be possibility of inflammatory diarrhea or bloody diarrhea. And if there is no WBC, is no calprotectin level is less than 50, it's a like water diarrhea, non-inflammatory diarrhea. Fecal calprotectin basically says whether it's inflammatory or not. In case of infections, in case of IBD, it can be increased. And if there is no white cells or red cells, fat globules are present, fecal calprotectin is negative. So we should do the 72 hours stool fat quantification for low fecal elastase. Like in case of pancreatic insufficiency, there will be low fecal elastase. Then we have to find out the causes of fatty diarrhea. Then, okay. Then from the previous slide, if you have found some causes among them, then we go for the treatment, and if not, then we again investigate for some other causes. Look for the edema, hypoalbuminemia, or lymphopenia. If edema or hypoalbuminemia is present, then we can do the alpha one antitrypsin clearance levels. So basically, alpha one antitrypsin is normally present in stool in trace amounts, but in case of that protein losing enteropathy, the clearance of the alpha 100% will be increased. So what we do is we take the 72 hours stool sample. Apart from that, the blood sample we also take, and then check the alpha 1 antitrypsin levels in blood and the stool samples and look for the clearance. If the increased clearance of alpha 1 antitrypsin deficient alpha 1 antitrypsin, it is suggestive of protein losing enteropathy. Then next we can do trial of fasting to differentiate basically whether it's an osmotic diarrhea or it's a secretory diarrhea. So we give a trial of fasting, and then we can check the stool electrolytes. We can check the stool osmolar gap, reducing substances or pH. So stool osmolar gap will be increased in case of osmotic diarrhea, and the pH reducing substances will be present in osmotic diarrhea. Stool pH will be decreased in osmotic diarrhea. So if the investigator is going towards the osmotic diarrhea, then we see the age of onset, whether it's a newborn, infancy, or it's older child. In case of newborn or infancy, there will be more likely chances of some congenital anomalies that can lead to diarrhea. For that, short bowel syndrome, for that we should go for CT abdomen or barium will follow through. And apart from that, endoscopy, biopsies, quantification of dural disaccharidases, like in disaccharidase deficiencies, they can present with these symptoms. In case of older child, we can look for the lactose intolerance or fructose or glucose malabsorption. If it comes for that, we can do breath hydrogen test. If it is positive, then we can do the dietary modification. And if it is negative, then we can go for endoscopy, biopsy, and quantification of duodenal disaccharidases to rule out the enteropathy. And if the child is having no, like we have given the trial of fasting and check the osmolar gap. The osmolar gap is less than 50, no reducing substances, pH is not acidic, and no response to fasting. That the episodes not improved after fasting. Then there will be possibility of secretory diarrhea. Then again, we have to look for age of onset. In newborn, again, the causes are more in favor of short bowel syndrome and other um, uh, uh, differential could be the microvillus, MVID, tufting enteropathies, and other congenital secretory diarrheas. And older child, we should rule out the structural disease. Apart from that, we should look for the neuroendocrine tumors. For that, we should do urine metanephrine levels, and NVIPomas, carcinoid tumors, castrinomas. They can present with these kind of symptoms. That's all.
Okay. So I think everybody's now clear about what should be the approach for chronic diarrhea and how to differentiate between the etiologies. The major etiologies that should be kept in the mind should be the infectious. In infancy, apart from infection, NEC or cow milk protein allergy becomes the most common causes. And above 6 month to 5 year infection and celiac disease apart from the GRDSS, immunodeficiencies. And above 5 is also for the chronic diarrhea apart from infection. Celiac disease remains the most common cause. But you also have to think about the rare causes in the approach to chronic diarrhea.
Yes.
And we are now open for questions. Is anybody having any doubts? They can comment in the chat box or they can unmute themselves or can ask question. I think there are no questions. So we can end this meeting now. Thank
Okay,
you.
ma'am.
Thank you,
Thank you,
everyone.
ma'am.
Okay.